Up next, Spencer King is joined by Dr. Daniel Lenihan, Professor of Cardiovascular Medicine and Director of Clinical Research at the Vanderbilt School of Medicine in Nashville, Tennessee. They discuss, are biomarkers helpful in assessing cardiac risk in patients undergoing cancer therapy? How do we apply this to clinical practice?
Tell us what you presented.
Thank you, Dr. King. I appreciate being invited. Probably the main point of my presentation was in what way can cardiologists assist in patients that are undergoing active treatment for cancer, and how can we do that in the most effective and sophisticated way? And cardiac biomarkers are certainly an important step towards doing that.
So cancer patients in general are being cared for by oncologists in general, and yet we know some of these drugs are toxic to the myocardium. How have we been measuring that toxicity, and how do we know that?
The long-held standard for detection of toxicity primarily is a serial change in left ventricular ejection fraction. And in order to be reasonably confident that you're seeing cardiac toxicity, that change had to be quite significant. So over the last 15 or 20 years, a significant reduction in left ventricular ejection fraction was considered tantamount to toxicity.
So that's a bit far down the road, I guess, trying to identify risk further upstream, huh?
Yes, certainly for those of us who think about ejection fractions or read echoes or caths or any other test that we measure the left ventricular ejection fraction, we know that that test has a lot of limitations, both just in terms of inter-reader variability, but also inter-test variability. So a change of 5 or 6 or 7% of an EF could just be a variation from one day to the next in an individual patient. And assigning some degree of toxicity to a drug with a small change in EF is really not a very sensitive way of detecting a problem.
So I know you've been looking for markers to help you predict this and taking markers that are not exotic because we're using them like troponin and such. What have you learned from using these measures? Are they predictive of degeneration, ejection fraction, or in clinical events?
Yes, actually, so you're right. We weren't trying to discover any unknown biomarkers at this point, but rather utilizing ones that we're very familiar with. So troponin, both I and T, can be very highly sensitive measures, and then BNP and N-terminal proBNP are all biomarkers that have been investigated in this arena. What I presented earlier in the meeting was the utility of BNP and troponin I in terms of detecting at the earliest point toxicity in a more reliable manner than just serial EF measurements.
So you found that these things can be helpful, but I'm trying to think about these cancer patients. They're being treated, as you've pointed out to me, their treatment's much more successful, of course, than it used to be. We have many long-term cancer survivors of all sorts. And given that, they develop cardiovascular diseases as well, maybe due to their cancer chemotherapy, but perhaps more often due to what the rest of us develop cardiovascular disease from. How should cardiologists be engaged? Because I'm thinking about these patients that are cared for by the oncologist. They say, that's my doctor, but they may be at cardiovascular risk. How should the cardiologist be engaged in the therapy for patients with cancer?
The truth is that I also presented this data, and others have presented similar data, that the cardiac risk profiles of patients that are undergoing cancer treatment is virtually identical to those that you see in your cardiology office. They have a high significant risk of diabetes, hypertension, hyperlipidemia, obesity, smoking, etc., family history. And so they're the same patients that you're used to seeing. And what you're trying to do is really prevent the development of heart failure or other acute myocardial infarction or other types of cardiovascular events. What these patients need is a cardiologist paying attention to the situation. I can tell you that all of the patients very much welcome that, and so do the oncologists, because they don't have to think about those things. They can be worried about the cancer-specific issues that they have to deal with.
You've made me aware of your interest in the nexus of cardiology and cancer therapy to the point that you formed an organization, as I understand it, to help bring the two together.
Yes, that's the International Cardio-Oncology Society, and has a strong representation of cardiologists and oncologists from really all around the world. And the whole mission would be to eliminate cardiac disease as a limitation for cancer therapy. So I think that whatever ways that we can optimize patients' cardiac status when they're undergoing these types of treatments is really what we're after.
Well, this seems very important in the clinical arena, but it also occurs to me that the interrelationship of cancer therapy and cardiovascular medicine is very much there at the basic level as well. Cell growth is very much a part of, obviously, cancer, and cell growth or suppression of it, a very important part of things in cardiology, like restenosis we're very interested in, cell vascular biology, and the attempts at myogenesis and angiogenesis now. So what do you see the future as far as the investigational, the research efforts of the oncology world and the cardiology world? Is there any reason they should join hands?
Absolutely. There are really some extraordinary examples that sort of resoundingly support what you're saying. For instance, Tom Forrest, who's a major person in the cardiology world, has done a lot of really elegant basic work looking at where this overlap is. For instance, if you just look at the definition of a tyrosine kinase inhibitor, which is a common description of cancer therapy, the definition, according to the NCI, is a drug that is probably going to inhibit cellular metabolism. That's sort of a general definition. And if you think about the myocardium as being one of the most active cellular systems in your body, then it's not hard to imagine that a tyrosine kinase inhibitor may affect the myocardium, and there are many different examples of that.
Well, it seems like there are many opportunities for research. Maybe the NCI and NHLBI can hold hands from time to time and trickle down to the rest of us doing investigation. I think a message perhaps for our listeners is that if they have patients who are receiving cancer chemotherapy, that encouraging them to stick with the cardiologist for their cardiovascular care, and possibly the measurement of these markers might be something that they could pick up problems before they occur, and that they should pay attention to your research and your future publications on this. Thanks so much for visiting with us here on ACCEL.
Thank you so much.